Okay, my work today is, or I asked for not a presenter view. For how I manage bone loss in revision ACL. Yeah, are there enough space for your anatomical channel? You have to see your patient first. If you have the metal like this, how do you put the tunnel to the new tunnel for revision? The definition of ACL failure is a clinical and measurement. Usually the patient come back with a recurrent instability. My job today is talk about how I manage bone loss. Usually the accepted tunnel widening is about 15 millimeter. That's all of the surgeon agree that maybe need bone graft, so I will focus on this. The hardware, remove it or not. It depends. If usually I kept the hardware and make a new tunnel. If the metal block your tunnel, I just remove that. So at first, for the metal, we keep that with before I make the tunnel. So the conclusion is remove whenever you need to remove. Okay, what is your weapon? You have many techniques to fill the bone gap. First is you just leave it and make a new divergent tunnel. Next, how to make a new divergent tunnel? You use a outside in, or now we have a retrograde drill. You use outside in guide or inside guide, or change the flexion angle of the knee, or make a new portal for the new tunnel. Next, matchstick, we call matchsticks, and the stack screw. I could show one case that I use this technique and change the direction. Next, everyone don't want to, is a two-stage procedure with the bone graft. Another is a screw filling the effect and make a new tunnel, divergent tunnel. So you have many options. It depends on the patient. What I need before, first, we need a plain radiograph that to evaluate the bone dilatation. The 3D CT is very important for me. The MRI scan usually for the associated lesion. The orthoscanogram is for association lesion also. So the lateral is quite widening of the tunnel. Yeah, special for me, I asked all the radiologists, I would love to see the CT like this and turn the CT in like a surgical scenario. This should be a good tunnel. So in my mind, this view maybe I reuse, and this is not a good. This is the two anterior of the femoral tunnel. Yeah. And I asked them to keep the tibia for me because I could explain the surgeon on my resident of my fellow that if you have a tunnel like this, you see it's a two anterior of the femoral tunnel. This patient should have a problem about limited knee flexion because the intra-articular graft is very short. The physiotherapist need to have a big force to make a full flexion, you see. So my fellow or even patient could understand because the intra-articular graft is shorter than the radius of curvature of the femur. So my step is different from the simple ACL. I perform an intra-articular examination first and then make a new tunnel before, and after that I take graft. Because it's a simple ACL, I take graft first. But in the revision, I just want to know the quality of the bone. Yeah, I put a scope and clean the tunnel and see what kind of tunnel is exactly. Yeah, it's my weapon. You need to have the outside in guide and the variety of reamer, and also this thing is for the bone graft, the old set, the articular set. That I take the bone from the nearer, I mean the tibia, the medial of the tibia may be lower from the ACL. Yeah. This is a guideline. Yeah, divergent, how you make a divergent tunnel technique. You change the knee flexion angle, or you use an outside in guide to make a new tunnel. So if you have a totally wrong tunnel, it's very easy. You make a new one, or you can make a double bundle revision. And if you have a totally wrong tunnel but bad bone quality, you can put the graft, or you put the stack screw in the previous one and make a new tunnel. If you have a correct bone graft but small size, you just use a larger bone plug and reuse the tunnel. If you have an anatomic but the bone quality is bad, you just put the graft and change the tunnel, change the direction of the tunnel. Or you can put, if you don't like bone graft, you can put screw and make a divergent tunnel. If you have a semi-anatomical, it's quite bad. Yeah, you just have like this, like a number 8 tunnel. Yeah. If you have this, you need to put the bone graft or make a new tunnel. If the divergent is not affected by the previous one, it's okay. You just put a new graft. But if the bone quality is bad, you put the bone graft or even the stack screw. 1 or 2 is okay for me. The first case is male 28. Failed ACL 2 years after surgery. Yeah, I checked the X-ray and CT, not too much bone dilatation, and usually should be a very good position tunnel, not bad. Yeah, and in the scope, I usually use like a 3 portal. This is from accessory medial portal. I check it's okay, so I just reuse the tunnel, make it flatten the bone and make it bigger one, and use the bone patella tendon bone graft, the larger bone. Yeah, okay, and use the screw. Each bone is okay, it's great. Continue that, and for the tibia we can change the direction more easy than femur. Yeah. For next case is infected after old-fashioned double bundle. So after clear the infection, the tunnel is quite bad. So I did not want to make it like only single stage. So I put the graft first. The graft is from the tibia, the medial side of the tibia. Use the old sets to take the graft, and I just tap the graft inside. But he is so unlucky. After graft cooperate, he also have another infection when I revision. So he quit. But 6 years later, he would like to be a soldier. So he come back to me 6 years later. I would like to do a ACL again. So we re-evaluate the cost of the tunnel is not, is quite, is okay, no associated ligament injury, and maybe the graft that I put, even it infect, is okay. So we go inside. We go inside and see, okay, the new place of the tunnel is quite good, so we can finish it. I use the peroneus longus graft to make a new graft for him. Right now it's 3 years. He still come back to see me. Yeah. Another case is a professional football player. Yeah. He performed a single bundle bone patellar tendon bone graft 2 years before re-injury and come to see me. The tunnel is not quite large, but I will show you. This is the CT MRI could not evaluate the quality of the bone. So this case I am decide to revision with the another side contralateral bone patellar tendon bone graft. Yeah, sorry. Go back. Can you go back one slide? Okay. Yeah, I use bone patellar tendon bone graft. Yeah, for the femur is okay. I can make a new tunnel, but for the tibia, the graft is a little bit long for him. So I try to put the first screw inside, but the graft still lags. So I put the second screw at the back of the graft. It still lags. So I put the third screw inside because I don't have the bone left at that time. So it's so lucky for me because the third screw saved my life. So I finished this case. He could be back to his professional. Yeah, he sent me the clip. Yeah, I can return back to my to his league. Yeah, he sent it to me. Yeah, after nearly 2 years of operation. So take-home messages: to avoid the stage procedure, remove hardware whenever it was obstruct your track. If the anatomic tunnel, just over-reaming and use a larger plug. Fill defect with bone graft or screw. I have many experience with the stack screw. Yeah, and the divergent technique can make a new tunnel, and maybe you add the bone graft or stack screw to make a new tunnel. Thank you.